This is Michael Altos recording Autonomic Nervous System Part 2, Adrenergic Agonists. In our last videos, we spoke about the entire autonomic nervous system and then focused on medications that work in the cholinergic system. In this video, we discuss drugs that work on the adrenergic system, specifically agonists. The thing to know about adrenergic agonists is that they have varying selectivity and specificity, so they can act at different receptors preferentially, and they can act there with different balance of selectivity. And there can be some overlap in their activity at different receptors. And sometimes the same drug can have different effects at different doses because the balance of activity shifts as dose changes. The first drug we'll speak about is phenylephrine, commonly called Neo-Synephrine. This is probably the adrenergic agonist you use most commonly, almost every day when you're doing general anesthesia. Phenylephrine is the closest thing we have to what we would call a pure alpha agonist. Its predominant effect is through direct alpha-1 stimulation, and therefore its primary effect is peripheral vasoconstriction in both the arterial and the venous system. It causes smooth muscle constriction in the blood vessels, and this will increase venous return, which increases preload, increases stroke volume, and ultimately will increase cardiac output and blood pressure. The most common side effect from phenylephrine is reflex bradycardia. This is a vagal reflex, which is probably mediated through baroreceptors. And the simple idea is that when the blood pressure goes up, the body compensates by making the heart rate go down. Thus, cardiac output remains largely unchanged. There's data that shows that phenylephrine will increase coronary blood flow. Phenylephrine is available usually in a small 1 milliliter vial at a concentration of 10 milligrams per milliliter. And depending on the institution where you practice, the custom would be to dilute it either the entire 10 milligram vial in 250 milliliters, which leads to a 40 microgram per milliliter solution, or dilute the 10 milligrams into 100 milliliters, which will give you a 100 microgram per milliliter solution. A common bolus dose is usually 40 to 120 micrograms if you are using the 40 mic per milliliter concentration, or let's say 50 to 100 micrograms if you're using the 100 mic per milliliter concentration. Phenylephrine can also be run as a continuous infusion. If you dose it based on weight, it would be 0.25 to 1 mic per kilogram per minute. Typically, people will run it just in milliliters per hour, in which case anywhere between 37.5 to 150 milliliters per hour. My common practice is to start it at 100 milliliters per hour, regardless of anything, and then titrate it up or down as needed for the desired effect. With all of this vasoconstriction, there has to be some compromise as far as end organ perfusion, and in fact we do see decreased renal perfusion at higher doses of phenylephrine. Phenylephrine does have some evidence of tachyphylaxis. Remember, tachyphylaxis is the idea that continuing doses of the same drug will have a smaller and smaller effect, and you'll have to increase your dose to maintain the same effect. And you may see this with an upward titration of infusion required. But I haven't seen this too much in my practice, and really ephedrine is much more common to show tachyphylaxis rather than phenylephrine. Moving on to ephedrine. Ephedrine is primarily an indirect adrenergic agonist. It does have some direct acting adrenergic agonist properties as well. Its effect is actually quite similar to epinephrine. Now, ephedrine is a non-catecholamine. It is a sympathomimetic drug, so it imitates catecholamines, but itself it is not a catecholamine. It has action on both alpha and beta receptors, and its primary effect, its indirect effect, is that it causes norepinephrine to be released. And then norepinephrine, as we know, binds to the alpha receptors of the smooth muscle in the blood vessels and causes blood pressure to increase. We can then understand why ephedrine is much more likely to show tachyphylaxis, because as these norepinephrine stores are depleted, the effect from subsequent doses of ephedrine could in fact be more blunted. Now, unlike epinephrine, which has a very short duration of action, ephedrine has a much longer duration of effect. And that's probably due to its indirect method of acting. It does cause venoconstriction more than arteriolar constriction. And what this accomplishes is it takes the blood that's pooled in the venous system and it redistributes it into the central compartment, and it improves venous return, which is improving preload. As I said above, ephedrine has some direct effects as well. Ephedrine has some direct beta action. And this is probably why we see an increase in heart rate with ephedrine. So phenylephrine increases blood pressure but decreases heart rate. Ephedrine increases blood pressure and increases heart rate. For many, many years, ephedrine was felt to be the drug of choice in OB anesthesia. As you know, we do a lot of neuraxial anesthesia in obstetrics, epidurals and spinals, and as we discussed previously, these patients can develop a sympathectomy due to the vasodilation, and they can become hypotensive. And it was classically thought that ephedrine was the treatment of choice because it preserved uterine blood flow better than the direct-acting alpha agonists like phenylephrine. The evidence for this statement is severely lacking, and in fact, current data shows that phenylephrine may actually be preferable as far as fetal outcome, fetal acidosis, and uterine blood flow. There's one point I would like to insert, though, which is that we need to consider the fact that patients who develop hypotension during a neuraxial block due to sympathectomy may be at risk for developing a high spinal block, which would cause bradycardia. And that, together with the reflex bradycardia that phenylephrine already causes, may be undesirable. So in general, phenylephrine is a better drug in OB than ephedrine, but in a patient who's already bradycardic or who's becoming at risk of becoming bradycardic, ephedrine may still be the better choice overall. Some say that ephedrine has antiemetic properties, and these properties are separate from its ability to raise blood pressure. And when we dose ephedrine in the operating room, a typical dose is 5 to 10 milligrams IV bolus. Ephedrine can also be given as an IM injection. Moving on to some more potent agents, the next drug is norepinephrine, also known as Levophed. This is the same substance that your body creates when we discuss norepinephrine. Norepinephrine causes direct alpha-1 stimulus without any beta-2 activity. So it causes intense arterial and venous vasoconstriction. And so it's an excellent vasopressor. It really increases blood pressure. It doesn't really cause any change in heart rate. Perhaps a little bit of reflex bradycardia. We'll discuss later on that there are some underlying beta activity in norepinephrine. Usually we only see this at very high doses or if the alpha effects are masked. With all of this vasoconstriction, we see decreased renal perfusion and may even see increased myocardial oxygen requirements. So we certainly want to make sure that patients are adequately volume resuscitated before we use norepinephrine. We don't want to be causing vasoconstriction when the tank isn't full of fluid. And because of all this vasoconstriction, we can actually see end organ ischemia and necrosis. This is not your best first-line treatment for cardiogenic shock because it doesn't really do anything to the contractility of the heart. It's really mostly a peripheral vasoconstrictor. It also causes pulmonary vasoconstriction. Norepinephrine is primarily used to treat refractory hypotension in patients who are in shock or septic. And the normal dosing range is an infusion running between 0.01 and 0.1 micrograms per kilogram per minute. It's recommended to give it only through central access if possible, because if the drug extravasates, it can cause tissue necrosis due to the vasoconstriction. From here, I'd like to discuss vasopressin, even though vasopressin is not really an adrenergic drug at all. Vasopressin is a non-adrenergic sympathomimetic drug. It's also a vasopressor, as its name suggests, and it works by activating the smooth muscle V1 receptors. This also causes vasoconstriction and increases blood pressure. Vasopressin is just another version of ADH, antidiuretic hormone, which is secreted from your pituitary gland. That hormone causes your body to reabsorb water in the renal collecting ducts, which is a part of your kidney, and it's normally used in the treatment of diabetes insipidus. The vasopressin that we're discussing right here is used to support blood pressure. In patients who go into septic shock, patients who have vasoplegia after coronary bypass. We also know that vasopressin is part of the ACLS guidelines and can be used as the treatment of cardiac arrest. We've seen that there's an interaction between ACE inhibitors and general anesthesia. And some of these patients during more complex critical surgeries may develop vasopressor refractory hypotension. And vasopressin seems to be the treatment of choice in these patients. So it's a very effective vasoconstrictor binding to vascular smooth muscle. It can be used, as we said, in ACLS at a bolus dose of 40 units. But more commonly, we see it given as an infusion at a rate of 2 to 4 units per hour. There are side effects with vasopressin as well. Because it's a vasoconstrictor, it causes vasoconstriction of the vessels in the skin, the skeletal muscle, in the intestine, in adipose tissue, and this can start to decrease blood flow in the splanchnic system, which is your GI system. Patients may even have an elevation in liver enzymes due to inadequate perfusion of the liver and some cell injury there. Patients who are awake may describe abdominal or uterine cramping and nausea. Lactic acidosis can develop from inadequate cell perfusion. Like the other potent vasopressors, it should only be given through central access if possible, because again, extravasation can cause tissue necrosis. Another situation where vasopressin may be preferable is in patients who are hypoxic or acidotic. There's some feeling that catecholamines lose their effectiveness in these patients, and vasopressin may be more effective until the hypoxia and acidosis can be corrected. So we've discussed vasopressor type drugs, and we'll take a moment to pause so you can think of any questions you might want to forward on to me or bring to class, and then we'll move on to the next group of drugs. The next drug we're going to discuss is dopamine. Dopamine is an adrenergic agonist that has effects at all of the adrenergic receptors, the dopaminergic receptors as well as the beta and alpha receptors. Dopamine has different effects at different receptors depending on the dose. So low-dose dopamine, which is considered to be less than 2 mics per kilogram per minute, preferentially activates the dopamine receptor. This causes some renal vasodilation and subsequent diuresis. It may inhibit release of norepinephrine in the renal and the splanchnic system. And for these reasons, people thought that maybe dopamine at a low dose would be protective for the kidneys. When a patient was at risk of renal injury, a low-dose dopamine would dilate those renal vessels and improve oxygenation and perfusion to the kidney. This concept is considered outdated, and there's no data to show that dopamine improves renal perfusion. You may still encounter some intensivists or anesthesiologists who believe in the idea of renal dose dopamine, but this is not backed up by any data in the literature. At higher doses, 2 to 10 mics per kilogram per minute, the predominant effect is at the beta-1 receptor. So we see cardiac effects, increased contractility and heart rate, and an increase in cardiac output. But we also see an increase in myocardial oxygen demand because of this heart work, which may exceed oxygen supply. And so you would be careful in a patient who has coronary disease, who is at risk for cardiac ischemia. This is probably the main reason you don't see a lot of anesthesiologists using this drug, because we don't like the tachycardia, and we don't like upsetting this demand versus supply balance. At its highest doses, dopamine has predominantly alpha effects. We see an increase in peripheral vascular resistance, we see decreased renal perfusion, and it becomes a vasopressor. Unfortunately, we also see more dysrhythmias at high doses. We see vasoconstriction of coronary and pulmonary vessels and increased pulmonary pressures. And so you can see at high doses, the advantages of dopamine are starting to be outweighed by the disadvantages. Where I see dopamine being used most in the anesthesia world is in children, where everything is about heart rate more than blood pressure, and this seems to be the pressor of choice for sick kids in the operating room. The other place I see dopamine being used a lot is in the medical ICU, but I've almost never seen it used in the surgical ICU under the supervision of our anesthesiologists. Moving on now to epinephrine, which is a direct adrenergic agonist and has different effects depending on whether the tissue involved is primarily alpha or beta. Its beta-1 effects cause an increase in heart rate and contractility, but again, that increase in myocardial oxygen demand, it does increase systolic blood pressure. The beta-2 effects cause bronchodilation, skeletal muscle dilation, and perhaps a decrease in diastolic blood pressure. The alpha-1 effects of epinephrine decrease blood flow in the splanchnic and renal system, but increase blood flow in the coronary and cerebral perfusion. All of these things together make up the classic fight or flight response. Epinephrine has a wide variety of uses. It's used to treat anaphylaxis. It's obviously the main ingredient in an EpiPen, and we use it in the hospital setting as well to treat anaphylaxis. It's used for ventricular fibrillation as part of the ACLS protocol. Risks of epinephrine include cerebral hemorrhage due to the high blood pressure, coronary ischemia due to the increased oxygen demand, precipitating ventricular dysrhythmias, again due to the beta-1 effects. And this issue of dysrhythmias is worsened in the setting of volatile anesthetics, and especially with halothane, almost to the point where halothane is really contraindicated relatively in patients who have epinephrine on board, either from an epinephrine infusion or a pheochromocytoma. Epinephrine is given as an IV bolus during ACLS, 1 milligram IV. So that would be if you have the 10 milliliter injectable vial that comes in a box during a code, that's 1 in 10,000 epinephrine, and you give the whole 10 milliliters. Or the tiny little glass vials that contain 1 milliliter, those are 1 in 1,000 concentration, and you give the whole 1 milliliter. And this just is a note for me to remind you that when we say something is 1 in 1,000, that means it's 0.1%, which is 1 milligram per milliliter. When a patient is in anaphylaxis or shock, we don't usually need to give the whole milligram. That's a little bit too much. So then we would give somewhere in the range of 10 to 100 micrograms IV, or even better, try giving it intramuscular or subcutaneous, 100 to 500 micrograms, to avoid that brisk hemodynamic response. When epinephrine is run as an infusion, the dose is the same as it is for norepinephrine, 0.01 to 0.1 micrograms per kilogram per minute. primarily to treat contractility, although you will certainly see an increase in blood pressure and heart rate as well. Where else do we see epinephrine being used? It's used topically as an infiltration, usually mixed with a local anesthetic, to cause vasoconstriction and decreased bleeding. And this is one of the reasons we add it to local anesthetics before a procedure is done. In addition, when we add epinephrine to a local anesthetic, it will prolong the block, because decreased perfusion to the area of injection will decrease clearance of the local anesthetic and prolong its effect. Another math note, I wrote here that the concentration of epi is usually 1 in 200,000 to 1 in 600,000. So if you have a 1 in 10,000 epinephrine vial, that's the little glass vial, if you take 0.1 mils of it and add it to a 30 mil syringe, that's 1 in 300,000. If you add it to a 20 mil syringe, you have 1 in 200,000, and so on. So that's a quick way to calculate how to do this. If you want 1 in 600,000, you can add 0.1 mils to a 60 mil syringe, or half of 0.1 mils, 0.05 mils, to a 30 cc syringe. We'll pause here for you to consider any questions and then move on to the next group of drugs. Isopreterenol, or Isuprel, is a drug you probably won't see very often. Isuprel is a highly potent beta agonist. It works both on beta-1 and beta-2 receptors. It has no alpha activity. And it increases heart rate and contractility. And it's an inotrope. Nowadays, we don't use these beta-1 and beta-2 non-specific agonists. We use more of a beta-1 specific agonist, which we'll discuss in just a few moments. These agonists at the beta-1 receptor can cause arrhythmias, as we've already discussed with epinephrine. And once again, it increases your cardiac oxygen requirements while decreasing myocardial perfusion. So these drugs need to be used with care in patients at risk for myocardial ischemia. Now, there's no alpha activity at all. So this beta activity, the beta-2 agonist activity, will actually decrease systemic vascular resistance and cause some peripheral vasodilation. This is why the diastolic blood pressure decreases. Why does the systolic blood pressure go up? Probably because the contractility has gone up so much. So your overall cardiac output has increased. Isuprel is also a bronchodilator, but nowadays we wouldn't use that just for the lung effects. We would go for a beta-2 specific agonist. And the most common use for Isuprel nowadays would be to increase the heart rate in the presence of heart block. If a patient's in heart block, something like atropine isn't going to help, but a direct beta agonist will help maintain heart rate until a pacemaker can be placed. Perhaps there might be some use for Isuprel also during an emergency in a patient who's had a heart transplant. Dobutamine is a selective beta-1 agonist. So this drug is a true inotrope, which means that it increases contractility, and that's how it increases cardiac output. There's also coronary vasodilation with this drug. However, in the balance, we worry about myocardial oxygen demand. The heart is beating more strongly, the heart is beating faster, and we worry about myocardial ischemia in patients who are susceptible. There's also the possibility of arrhythmias, especially at very high doses. There is some very weak beta-2 activity, which would cause a little bit of pulmonary vasodilation and a little bit of hypotension. So you want to be careful with these drugs in patients who already have hypotension. And often you find yourself in this difficult situation where you believe that the patient's hypotensive because they have poor contractility and poor cardiac output, and you're hoping that by increasing those you'll increase blood pressure. But in the same time, you're worried that if it doesn't work, you're going to be faced with more hypotension. There is some underlying alpha-1 activity with dobutamine. Normally, we don't really notice it. But if you give somebody a beta blocker and then give them dobutamine, so all of these beta effects will be canceled out. And all that's left is the alpha activity, and then you'll see hypertension. But most of the time, the beta-2 activity overrides this little bit of alpha-1 activity, and we see predominantly hypotension. The dose is 2 to 20 mics per kilogram per minute. Its onset is quite fast, and it's a short-acting drug, so it's quickly titratable. Related to dobutamine, I'd like to discuss Milrinone, whose brand name is Primacor. Milrinone is not an adrenergic drug at all. It's actually a phosphodiesterase inhibitor. And there's what it does is it inhibits cardiac phosphodiesterase 3, which increases myocardial cyclic AMP and causes inward movement of calcium. And all of that functions to increase contractility. So this is another drug that's an inotrope, but it also causes muscle relaxation in the vasculature and in the airways and in the smooth muscles. So people commonly refer to it as an inodilator. It's an inotrope, but a vasodilator. Milrinone has very little effect on heart rate, and that's probably one of the biggest differences between Milrinone and dobutamine. Dobutamine is going to increase the heart rate and probably increase your risk for tachydysrhythmias. Milrinone really doesn't affect your heart rate very much. Similarly, we worry about myocardial oxygen demand with dobutamine. We don't have that worry as much with Milrinone. Milrinone is a very effective pulmonary vasodilator, which we did see that effect some with dobutamine as well. And once again, this effect on SVR, which leads to hypotension. So in those respects, the two drugs are similar. The dose for Milrinone is usually a bolus given over 10 minutes followed by an infusion. And because its onset is a little bit slower, you can't titrate it as immediately as you can dobutamine. The drug is renally excreted and so should be used with caution in renal disease. If I had to summarize the biggest difference between these two drugs, though, would be the effect on heart rate and myocardial oxygen demand. Pause here for a moment to see if you have any questions or points you need clarified, and then we'll move on to the last section. The last drugs I want to discuss are sort of a miscellaneous collection. The first is Fenoldopam. I'm not sure why I even still discuss this drug, except that it continues to pop up in the textbooks. I don't think I've ever seen it used, maybe once. And I'm not sure that I believe it'll ever show up on an exam. But we'll just discuss it briefly. Fenoldopam is another dopamine agonist. It doesn't have any alpha-1 or beta activity. It has a little bit of alpha-2 activity. And so it increases renal blood flow and it's a diuretic. It also decreases peripheral vascular resistance, which leads to a reflex tachycardia. And the side effects are headache and flushing, tachycardia, hypotension. People can become hypokalemic. That's probably from the diuresis. It's also rather expensive. And there isn't much more I have to say about Fenoldopam. Clonidine is definitely a drug we should be well aware of. Clonidine is a selective alpha-2 agonist. It's about 200 times more specific for the alpha-2 receptor than the alpha-1. Clonidine is used to treat hypertension. There are alpha-2 receptors in the vasomotor centers of your brainstem, and when it binds to them, it decreases sympathetic outflow. And related to this, Clonidine has sedative properties. It can be used as an anxiolytic or as a sedative. It's known to decrease MAC. Clonidine can be given in a number of different routes. It's available as a pill, as a patch, as an IM injection. It's available IV, although you don't really see it used IV in the United States. Side effects are bradycardia, hypotension, and dry mouth. As I already mentioned, it's a sedative. It's also effective against postoperative shivering. And it's been used as an adjunct for analgesia. So it's been added to local anesthetics or opioids for epidural blocks, spinal blocks, nerve blocks. So clonidine is a pretty versatile drug. When patients are on clonidine and then they stop taking it, they undergo withdrawal syndrome and can have a very malignant hypertensive crisis. One other drug, which we've talked about before briefly, is dexmedetomidine, which is another alpha-2 agonist. In fact, it's even more alpha-2 specific, 1,000 times, more than 1,000 times, preferentially binding to the alpha-2 versus the alpha-1 receptor. And that's a drug used primarily for sedation. It does have some of these side effects as well, of the bradycardia and the hypotension. That's it for this lecture. Let me know if you have any questions, and we'll see you in class.